Hey everyone, we will be getting started. If you're joining from YouTube or Facebook, welcome, welcome. If you're joining from Zoom, also welcome. I think I see some familiar names in here, so that's awesome. Give everyone just one more minute to get on in here. We will be talking all about eyes and ears today. All right. Well, if you are new, it is great to have you here. My name is Rachel. I am a family nurse practitioner and the program director here at Archer Review. And today we will be talking all about the eyes and ears. So everything about the eye exam, the ear exam, abnormal findings, normal findings, things that you want to look for in the outpatient setting. And then we will do a couple practice questions from our practice question bank and have time for questions at the end. If you have any questions during the webinar, please feel free to throw it in the chat. We have Morgan in the chat, and I'm also able to see the questions. So I am happy to answer those for you. All right, so we will get started here. So just a little icebreaker. Where is everyone joining from? I am currently north of Boston, where it is very cold. So hopefully you are somewhere that is maybe warmer. But if you're not, sending you lots of warm thoughts at least, because it is definitely cold up here. I see a New Jersey. I think I see someone on the West Coast, hopefully somewhere warm, although I know the weather all over the country has been crazy right now. We're gearing up for another big snowstorm, it looks like, on the East Coast. Or not so big, but it's winter, it's January. So I am glad you have all chosen to be here. And this will be up on our YouTube page as well if you missed something or you want to just review it again. So don't worry if you missed something during the webinar. We'll see you on YouTube. So let's go. Our first topic here is something that you actually probably won't look at too much in the primary care setting, but it's really important to know. And that is what a normal fundoscopic exam looks like. So this is a really great picture. I think it really shows the different pieces, and we're going to talk through it together here. So when I'm looking at a fundoscopic exam, and granted, I am not an eye expert, a little tip is always have a good ophthalmologist that you can call locally, because sometimes those eye complaints come in and you just have no idea what you're looking at, or someone's describing some sort of eye weakness or deformity or pain and you have no idea. Always good to have an ophthalmologist to call and say, hi, can you see this patient semi-urgently? Because sometimes the easiest way is through the emergency room. And especially in URI season right now, it is a long wait unless you are super acute. So always good to have those specialists on speed dial. So the first thing I look for is that optic disc. And you can see it has that distinct round or oval shape. The optic disc is typically creamy or pink colored, nice and healthy, looks like a little donut more or less, or like a tube or something, like an inner tube, something like that. Just really round. Don't want to see any deformities on that, any sort of like blurred edges, and definitely no swelling. The central cup, which is that depression in the center of the optic disc, so kind of that little divot, may be present but not excessively large. So if it looks more circular to you and less like a tube or a donut, that can be normal too. So don't worry if you don't see that very classic donut shape. So then we look for the retina, and the retina should have that uniform, consistent color. And then the macula, which is at the center of the retina, is a smooth and slightly darker area of the retina there. The fovea is that small depression in the macula. Very hard to see in this picture, just kind of something to note. Unlikely to see it on exam. It is very small, but that is present, and it might show up as a slightly darker spot. As you can see, tons of blood vessels in the eyes, as you know. So those arteries and veins should be visible all throughout the retina, all throughout the fundoscopic exam. So you see them just branching off there. Nothing looks like it's hemorrhaging or bleeding or bulging, nice and healthy. And we want them to all have that consistent caliper. So you can see they're all about the same size. So the arteries and veins are about the same size throughout, little differences here and there, but nothing major. And then the background of the fundus, so this whole thing should be very clear without any abnormalities. And we'll look at some abnormalities in a minute, but we really just want to make sure that it's nice and clear, consistent coloring. This one looks beautiful. That, like I said, this is a perfect fundoscopic exam. And then we also want to see that light reflex. So the red reflex is caused by the reflecting of the retina, and that should be symmetrical in both eyes. That's a pretty easy exam to do. You can take your little scope. Sometimes I even use the otoscope to get that red light reflex if it's what's in my hand. You can use a pen light, a flashlight, anything like that can get that red reflex. This is especially important in children. So if we have a child, and sometimes the parents bring this up and they say, sometimes in pictures, one of their eyes shows up white. That should be a large red flag to you that something might be going on. And it might be something as serious as a retinoblastoma or even congenital cataracts. So this is a classic thing the boards like to ask about is what if the child had a red light reflex in one eye, but not the other eye? Definitely a red flag, definitely needs to be investigated. Sometimes a good way to have parents check this is when the child is in the bath, having them just look up can really show if one of those eyes has a white reflex instead of a red reflex. So now that we looked at this beautiful normal fundoscopic exam, let's talk about a few abnormalities. So on the left here, we see these little white spots, a little fuzzy on this picture, but that's what I'm looking at here. These little white, fluffy, might be a good way to describe them, spots. Can anyone throw in the chat what these are called? They're named very appropriately. I see some correct answers coming in. This is one of my favorite abnormal findings because it's very easy to recognize and has a name that goes right along with it. No crazy names here. Looks like everyone's got it. These are cotton wool spots. So they look like little balls of cotton, little fluffy cotton balls there. And these can be a hallmark sign of retinal arteriosis, which is caused by diabetes. Sometimes we see this in hypertension as well, but it really goes hand in hand with diabetes. A good way to remember it is cotton wool, cotton candy, sugar, diabetes. That's how I tie it all in together in my brain. But wouldn't be the craziest thing in the world to see it in hypertension as well, although that patient should be checked out for diabetes. So if you ever see these on your exam, definitely warrants further investigation. Now, what about this next picture? This one is super serious, and this is something I said we absolutely do not want to see on our exam ever. You see this big swollen spot here. What is this called, and what might be going on here? This is much more serious than cotton wool spots. This is something you hope you do not see. It looks like everyone has this one too. This is papilledema. So this is an emergency when the optic disc looks big and fluffy like this, not even fluffy, swollen, puffy, not a good thing. This can be due to uncontrolled hypertension. So really, really high blood pressure. I'm talking like 200s on 120s, hypertension, emergency, urgency, really bad. Or it could be due to a head trauma, a facial trauma, increased intracranial pressure. But anytime you see this, this is an emergency. We need to send this patient out immediately, likely to the emergency room, unless you have an emergent ophthalmologist right on hand. So let's talk about a facial condition now that can affect the eyes, and that's herpes keratitis. This is a little bit of a more rare finding, but definitely something you don't want to miss. Patients often say they have this acute onset of severe eye pain, photophobia. So that means, the light is hurting their eyes, and then some blurred vision as well. On exam, you might see a reddened eye. They often come in squinting because it hurts so much. They might have some discharge outside their eye just from the pain. They might also have like a small crusty rash around the eye. That's not unheard of as well. But this is something that we definitely need to investigate. And we usually use that fluorescein staining. Does anyone remember what we use fluorescein staining in typically? What does that help us diagnose? And that's when we just put the numbing drops in, the little staining drops, and then we shine that black light right on it, and it shows us abrasions. What type of abrasions are we looking at? Definitely everyone knows their eyes. This is corneal abrasions, also can use that fluorescein stain. So this is a really great way to rule out serious conditions versus something that is uncomfortable, but will get better in time with those corneal abrasions. So let's talk about the differences. So herpes keratitis, we see these furnings. So see that on the side, that's called furning. If you are familiar with OBGYN, this is also kind of what amniotic fluid looks like under the microscope, but you can see there's a little center and then it goes out from there. So that's a little bit different than a corneal abrasion, which oftentimes you can't see, or it just is like a reddened area. Granted, if they have something actually stuck in their eye that's causing the corneal abrasion, you might see something much bigger. But the furning really gives away that it's herpes keratitis. So when you put that fluorescein staining into the patient's eye and you see furning, that can help you rule out corneal abrasion or herpes keratitis. Unfortunately, herpes keratitis can be a permanent condition. So this is something we really need to have these patients follow up on. Whereas something like a corneal abrasion usually gets better in a week or so. And we actually usually can't see it. Patients might just say, I feel like I have sand in my eye. I can't get it out. I've tried flushing it. It won't budge. That's usually a corneal abrasion. And you'll usually just see a very small little scratch when you're looking at the cornea with the fluorescein stain. Usually we do prescribe some antibiotic erythromycin ointment for corneal abrasions, just in case any sort of bugs try to get into that abrasion. We don't want to cause a larger infection there. Now, what if our patient had a tingling, crusty red rash on the side of their face? Kind of looks like this. It's along a dermatome. It might be in their eye a little bit. It might extend to their ear. What might be going on then? What would we suspect? Everyone a second here to answer. Everyone's right on with this one. Definitely herpes zoster or shingles. And again, because this is on the face, this is actually an emergency. Because if shingles gets into the eye or that herpes zoster virus gets into the eye, it can be a permanent condition and cause blindness. So unlike regular shingles, which stinks for patients, it's very painful and uncomfortable. We usually just give those antivirals and we can treat them outpatient. Herpes zoster or shingles on the face, especially near the eye, we usually need to treat as more of an emergency. Sometimes they even need to go to the emergency room for treatment so we can get that virus and that inflammation under control before anything happens to their sight. A question the exams love. What if the patient had sudden painless, and that is the key, loss of vision? And you can see it right on here. And sometimes this is actually not super sudden. So sometimes this happens over like an hour or so, but a lot of times it's sudden, and they might say like a curtain's coming down over my eye. Like I just feel like I can't see, but it doesn't hurt. And because it doesn't hurt, as we know, lots of people don't seek help when things don't hurt. So they might have waited a little long, but it is okay. What are we thinking this is? Everyone is spot on here. This is retinal detachment, like it says. So you can see that retina has fully pulled away there. And this, again, is an emergency. We are not treating this outpatient primary care. We are sending them over. Sometimes they need surgery to retouch that retina and not lose their vision, which is the goal of all eye care, to preserve vision and eye health. But always look for that key word in exam questions of painless, because this is one of the only eye exam questions that has painless in it. Most eye things are very painful. If you've ever gotten a hair in your eye, even, it's very uncomfortable. But retinal detachment is one that is painless. So continuing on with the eyes, let's talk about a normal vision exam. I'm sure you have all had this many times, done it to patients many times. If you've worked in pediatrics, you've probably done this 100 times a day, because this is our Snellen chart. So that is the one with the letters. Sometimes for little kids, we use pictures or symbols because they don't know their letters yet, which is understandable. And this is how we test 20/20 vision. And 20/20 vision just means a patient standing 20 feet away from the chart, from whatever they're looking at, sees what is expected. So what the normal population with normal eyesight sees. What would a 20/40 vision mean? So a patient has 20/40 vision. What is their vision like? Looks like we got some good description. So 20/40 vision means that a patient standing 20 feet away sees what a person with 20/20 vision sees at 40 feet away. So basically, they have worse vision because they should be seeing, this big E crystal clear 20 feet away, but they're seeing it small and blurry with what someone at 20/20 vision would see 40 feet away. So just think, if you're 40 feet away from a television, you are not going to see that picture as well as if you're 20 feet away. But this person at 20 feet away is seeing what you see at 40 feet away. So definitely need some corrective lenses, perhaps some contacts there. And what is considered legal blindness? This is another little tidbit the exams love to throw in there. It's 20 over a big number, definitely larger, much larger than 40. They are not blind at 20/40. Oh, I actually see it there. 20/200 is considered legal blindness just based on eyesight. Obviously, there is a wide array of things that can cause blindness, but 20/200 is considered legal blindness. That's just something to have in your back pocket. Sometimes the exam questions are literally as straightforward as that. They will say a patient comes in, you test them, their vision is 20/200. What is this considered? Legal blindness. Easy, easy peasy points there. What about peripheral vision? You can see this patient here is performing this exam. What is this called? I think I see some out there. So this is the visual fields of confrontation exam. So you just have the patient cover their eye, and then you're going to move in from the side because you're testing their peripheral vision. So pretty easy to perform in office. If you are really worried about patients' eye exam, I would refer them out. These are just very basic exams that we can use to get down what might be going on with these patients. And then what is this? If you can see the A in the middle of this circle, you are not colorblind. So good news there. But what is this colorblindness test called? Sometimes you see these in like magazines or like little fun books of, can you see the numbers? Can you see the letters? If you can see this one, you do not have red-green color blindness. Should be an A in the middle. If you can't see the A, you might be colorblind. All right, I see one answer there. This is the Ishihara chart. So this is just a test for color blindness. Another thing we do typically in pediatrics, actually, and remember, color blindness is more prevalent in males, technically can be in females as well. So I know I heard growing up only males can be colorblind. It's not technically true. They're just much more likely to be colorblind. So just something to keep in mind. And we can test this on children with symbols, you know, an airplane or a heart or something in the middle, or letters work too, but definitely can use this as an easy way to rule in or out color blindness. A lot of patients have absolutely no idea that they are red-green colorblind because that is just how the world looks to them. And it doesn't mean that they see things in black and white. It's just more of like a brown color they usually describe it as, and they can tell the colors are different. So they might say, you know, I see a brownish A in the middle of this circle, but we know if you are not colorblind, it should be kind of orangey red. So they might still have color blindness, but be able to differentiate there. So it's not like they see everything like dogs might see it in very muted colors. Just the red and the green sometimes get a little mixed up there. So let's go on to vision loss. What is that most common cause of vision loss in our older population? Does anyone remember? This is a picture of it. If you look very closely here, you see something happening with that macula. It's a little hint. That's right. This is macular degeneration. This is a slow onset process, and it is the most common cause of vision loss in our older population. This is something we definitely want to refer out to ophthalmology. They'll do something called an Amsler grid test, which if macular degeneration is present, the patient will say there's a distortion of the or a scotoma, a blind spot in the center of their vision. So they might say, you know, I feel like I can't see things head on. My peripheral vision is fine, but I'm looking straight ahead. They might even say things like, the lines on the road look disconnected or something like that. That should be some red flags that this is macular degeneration, and they definitely should be referred out. And what an Amsler grid is it's just a photo, and the patient tells you literally if they cannot see the whole photo or if they can. And if they have that scotoma, that blind spot in the center of their vision, definitely highly suspect macular degeneration. This is usually managed by ophthalmology. Unfortunately, it can cause permanent vision loss. We don't have super great treatment for it at this time, but it is very common. So hopefully someday we will have better treatment and better exams to catch it earlier on before it progresses to that true scotoma, loss of vision in the center. Now, on the flip side, if that patient has that gradual loss of peripheral vision, what type of glaucoma might that be? Open or closed? So this is the gradual loss, and it's very common. It's the more common one. And yes, I do see some questions. This is also painless. Yep. Well, one of them's more painless than the other. So yes, this first one is painless. It's gradual loss of peripheral vision. Might have not bothered them. So primary open angle glaucoma is most commonly seen in diabetics and those of African or Caucasian ancestry. So when we think of glaucoma, this is the one that's not an emergency. But if we see closed angle glaucoma, this is definitely an emergency. So let's talk about them. Open angle is that gradual loss of peripheral vision. I'm thinking that they might have a little bit higher intraocular pressure. Normal is 11 to 12-ish. Theirs is usually in the 20s. So a little high. We can even see some people call in the early 20s, like 20, 21-ish normal, but most people like to see it in the 11 to 12 range and really call that normal. So open angle, they're maybe like a 22, 23 intraocular pressure. Nothing crazy, but definitely something we need to look into. If the IOP is above 30, we definitely think they might be having that closed, they're the primary angle closure glaucoma, sometimes just called closed angle. This is an emergency. So their IOP is very high, that intraocular pressure. And this is something that we absolutely need to refer out because they can have complete loss of vision. Much more rare to see that closed angle. Open angle is much more common in the primary care setting. Either way, if you're not comfortable measuring intraocular pressure, which a lot of places in primary care don't even have the tools for that, send them on out to ophthalmology for an urgent visit to have it assessed. Obviously, if you're suspecting closed angle glaucoma, send them over to the emergency room. And what the big difference too is closed angle is very painful. Usually they are saying that eye is throbbing. They can't see, their eye is throbbing. They might be pushing on it to reduce the pressure. So that is something that red flags are going off in my head. I'm sending them over, giving a handoff to the nurses in the emergency room. Just a few more things to talk about. Why do we tell patients to never sleep in their contact lenses? I know it happens once in a while, but what is that big thing we are worried about? If a patient is sleeping in their contact lenses, what can happen? I'm thinking something might be caused by like staph or pseudomonas or strep. What do they cause? I am seeing it, those corneal ulcers. So corneal ulcers are definitely an emergency, and this can happen from sleeping in contact lenses because the contact lens dries out overnight and it kind of rubs on that cornea. And we know with any breaks in the skin, any breaks in the cornea, our friends, staph, pseudomonas, and strep love to make their way in. So really, when we have patients with contact lenses, super important to advocate for them taking them out at night, not showering in them ideally, although that's not as realistic for most people, but most people can take them out at night and either toss them if they're dailies or put them in their special solution if they are rewearable ones. Now, what if a young Caucasian female in her early 30s came in complaining of loss of visual acuity over the last week? She also tells you her color vision just feels off. So it doesn't feel like She can't see any colors, but it feels a little off. What might that be? And this is something you don't want to miss in primary care because it's indicative of a larger diagnosis. This is a tough one. So I'm definitely thinking optic neuritis. And optic neuritis can be caused by something like multiple sclerosis, also called MS, which we know is a larger degenerative disorder and something we definitely don't want to miss. So anyone's coming in for the loss of vision over the last week or two, color vision feeling off, this is something I definitely want to think about, is that optic neuritis. And we don't want to let that go. We want to refer them out. They might need ophthalmology and neurology on board if it truly is being caused by MS. So one of our most common eye complaints, you will see this all the time in primary care. If you're a nurse, you probably see this all the time already. This is conjunctivitis. Lucky for us, conjunctivitis is pretty easy to diagnose and treat. But let's talk about the different types. So we have bacterial conjunctivitis, which honestly is the stereotypical eyes glued shut, yucky, purulent drainage coming out. Eye might be a little itchy, might be a little painful. Patients are a little uncomfortable. They might say they have been sick for a couple weeks, something like that. This is bacterial. This needs antibiotics. So we usually do that simple erythromycin eye ointment, a little uncomfortable to put in if you've ever used it or given it. It's that strip that you put in patients' eyes, causes a little blurry vision, best given at night or right in the morning where they can kind of rest their eyes for a little bit. And then we educate these patients to clean their pillowcases, try not to touch their eyes, definitely try not to touch their eyes and touch other people because this is so contagious. And a giveaway on bacterial conjunctivitis, especially for your exams, is that a lot of times the exams will say this started in one eye and moved to the other eye. Ding, 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 going off in my head, bacterial. And that's because viral and allergic conjunctivitis typically affect both eyes at the same time because they're due to something going on in the body, some reaction, some virus, not a bacteria infecting the eye. So viral conjunctivitis is actually pretty common, but sometimes it's hard to differentiate from bacterial conjunctivitis. So we might see patients getting erythromycin ointment for a more questionable case of viral conjunctivitis, just because clinicians are worried they might miss bacterial conjunctivitis. But if a patient has other viral symptoms like a cough, a runny nose, and less acute eye symptoms, like not as purulent of drainage, their eyes aren't stuck together, it doesn't have this yellow coming out of it, it's more of like a watery drainage, then we can pretty confidently say it might be viral conjunctivitis. Usual viral causes are things like rhinovirus, herpes viruses, Coxsackie virus is famous for this, and even COVID-19. We do see a lot of eye complaints, especially recently, it seems, with COVID-19 infections. So for viral conjunctivitis, we would not need the antibiotics, obviously. We can do symptomatic care. We would still want them to clean their bedding and stuff to get the virus out, but it should get better as they get better as well. Just might be a couple days of discomfort. And lastly, allergic conjunctivitis. This one has one hallmark way for us to differentiate. And this is when patients say, I was outside and then my eyes turned like this. So this is easy. This is not bacterial. This is not viral. This is allergies. So much easier to diagnose because they had a contact with something that irritated their eyes. So this is, again, symptomatic treatment. We can even do antihistamines, have them try to avoid whatever caused it. And then we would know that it also is allergic conjunctivitis because their eyes are so itchy. It should get better as they move further away from whatever caused it. But if it's in their house or it's like a chemical they're around, it might be hard to weed it out. So let's just talk briefly about hordeolums and chalazions. So sometimes these are both called styes, but what is actually a sty is a hordeolum. So this typically resolves on its own. It might be very small on the lid, kind of looks like this picture here. We can recommend some warm compresses. It shouldn't drain anything, maybe tiny, dead skin or something like that, but nothing too serious. A chalazion's a little bit more serious because it is caused by bacteria. So we might be worried about it causing orbital cellulitis, and then we're going to refer them out or get them on some medications like dicloxacillin or erythromycin. And this is because that gland is swollen, the little sweat gland there. It can still resolve on its own, but sometimes it requires IND, which I typically do not IND eyes in the primary care setting. So we typically refer them out. So I just like to think hordeolum, sty, not serious, chalazion, more serious. That's a good way to just have it differentiated in your head. So a couple more things before we talk about the ears. We have two pictures here. We have pterygiums and paniculas. Very silly names for actually pretty benign conditions. So this one is just a raised yellowish growth there. You can see this is a pretty good depiction of it. The main difference is pterygiums go into the eyeball and they are formed in these kind of triangular patterns there. I like to think the Y in pterygium kind of looks like a triangle to help me differentiate. These can be caused by sun exposure. Some people are just born with them, which is kind of interesting. But the best way to have patients get rid of them is to wear sunglasses. So both can be caused by repeated sun exposure. We typically see these in surfers a lot, actually. So, they might come in and say, what is this growth in my eye? It is not painless. It is not causing any loss of vision, but they definitely need to wear those sunglasses or the eye protection. And what if your patient comes in with this? So they have all this blood in their eye. What is this? Looks very serious. It is actually not very serious, surprisingly. That is right. So this is a subconjunctivitis. Oh my gosh, speak right now. Subconjunctivitis hemorrhage. My goodness, I am losing it right now. Even though it looks pretty gnarly, it's not serious at all and will go away on its own. This is common in little kids, especially if they're vomiting a lot or, they even sneezing really hard. Some people might get it in labor when they're pushing, and it's just the broken blood vessels. They will absorb. It just looks pretty ugly for a while. You can do some warm compresses, things like that can help them go away. But it's not serious, even though it looks pretty serious, and it might freak patients out. So let's talk about the ears. What if you looked in those ears and see that hallmark red bulging tympanic membrane? They might have a fever, ear pain, classic case of something. I'm definitely thinking what you're all thinking, otitis media, just that good old ear infection. Can be caused by a variety of things. Sometimes the pneumonia viruses cause this. Sometimes the H flu viruses cause this. And we typically use just regular old penicillins to treat this. If it doesn't get better on their own, we might up the treatment to augmentin or even a cephalosporin. But just think about that red bulging tympanic membrane, definitely thinking ear infection, otitis media. What if the pain is on the outer side of the ear? So they say their outer ear is hurting. Maybe they had been swimming recently, something like that. Might have some drainage coming out, pain with movement of the pinna. That's a good giveaway. Definitely otitis externa. Everyone is right on top of this. This is typically caused by Pseudomonas and sometimes even Staph aureus. In otitis externa, we usually just use drops for that. So some corticosporin or ofloxacin drops usually. No oral antibiotics needed because it's the external ear canal that is infected, not the internal ear canal. And that is one we see a lot of times in the summer. So very, very common to see that because water gets stuck there, Pseudomonas starts to procreate, and then they have an infection. So let's talk about this patient here. We have a 58-year-old male with left-sided hearing loss and vertigo for 3 to 4 years. So a long time. He's waited. He kind of felt better, but it is getting worse. What are we thinking? That's right. I'm thinking an acoustic neuroma. So I want to point out that this patient had some demographics given for a reason. So we typically see these in the Asian population between 50 and 60 years old. On your exams, if the patient's demographics are given, it's usually for a reason. So don't overlook that. Add that into what you're thinking about. It's usually there for a reason. And this affects what cranial nerve? Remember, it's a tumor on this nerve. Cranial nerve 8, that is right. That acoustic nerve, sometimes called the vestibular cochlear nerve, it's a double name nerve. So that is cranial nerve 8. And we are going to send these patients right over to neurology to have them assessed. Sometimes ENT takes care of it, but more commonly neurology actually does. What if you looked in a patient's ear and you saw this cauliflower-like growth here? It's obviously not going to be this in-depth. This is just a drawing of it, but it looks like a big old piece of cauliflower inside of there. What are we looking at? This is definitely a cholesteatoma. This might have some smelly ear discharge and hearing loss as well. And we're going to just refer them out to ENT. So everybody's favorite, the RIN and the Weber test. I'm going to start with the RIN, sometimes called the Rhine or the Rinny. I've heard it pronounced either way. I say the RIN or the Rhine. So this tests for conductive hearing loss. So in a normal test, AC, air conduction, is greater than bone conduction. And all that means is the patient hears the noise from the tuning fork for a longer amount of time when it is pulled away from the ear than when it is touching their mastoid process. Very simple. AC, air conduction, is heard longer than BC, bone conduction. So an abnormal result would be BC longer than AC. They say, nope, I heard it better when it was touching my mastoid process. So just think of all the C's with this test. It only tests for conductive. AC, BC, RINI. I like to rhyme them all together there. Things that can throw this off are things you can see. Again, with the C's, if you see it, conductive hearing loss. Might be an otitis media or something like a cholesteatoma. If you can see it, we're thinking conductive hearing loss, and they will have an abnormal RIN test. Now on to the Weber test. So this is a little special, is it can do both conductive and sensory neural hearing loss. So conductive is something we can see. Sensory neural is something we cannot see, something like Meniere's disease, for example. For this, we're going to strike that tuning fork and put it somewhere midline on the patient. So their face, their top of their head, something like that. A normal Weber test is called no lateralization. So this just means they have equal hearing in both ears. They say, nope, sounds about the same in my right ear and my left ear. An abnormal result is if they say, it sounds louder in one ear. So that would be abnormal. And if it's lateralizing to the good ear, so the ear they're saying they have no trouble hearing in, we're suspicious of sensory neural hearing loss. If it's lateralizing to the bad ear, we're suspecting conductive hearing loss. And how would we confirm that? With the Rhine test. So if we're suspecting conductive hearing loss, we can say, I know how to test that further. And they would likely have BC larger than AC as well. So just think B and C still go together here. The bad ear is conductive. And here is a picture. So the Rhine test, we're going to strike that tuning fork and put it right on the mastoid process or some part of the bone right behind the ear. And once the patient can't hear it anymore, they say, okay, the sound is gone. We pull it away. So this is no longer touching the patient. It's a couple inches outside their ear. And we say, okay, can you still hear it? And they should say yes. So air conduction, the sound going through the air, is longer than bone conduction. This one's my favorite because it's very simple and straightforward, but don't get tripped up. Just make some ways for yourself to understand it. Practice it on yourself. I think every school requires people to use tuning forks. I'm not sure in practice how often tuning forks are used, but it can be a good way to really apply it to real life. And you can see the Weber test. So we put it on the patient's forehead, top of their head. Some people even put it on the nasal bridge, and we look for lateralization. So no lateralization like this picture means they hear it equal in both ears. If they say my left ear is losing hearing and it sounds louder in my left ear, so it's louder in the bad ear, that would be conductive hearing loss. They say my left ear is losing hearing, but it sounds louder in my right ear. That is the good ear, and it's sensory neural hearing loss. These are things I would definitely know for your exams. I'm pretty sure most people have seen a question thrown in about these. They're very simple. They will say, you know, the patient came in, you do the Weber test, it's on their head, and they say it is going to the bad ear. What kind of hearing loss is this? If you need to make some pictures for yourself, that is totally fine too, but I would just know what kind of hearing loss it is and how we test for them, and you will be golden. So one last topic before we wrap things up, and this is a very, very common complaint in primary care, and that is vertigo. So we again are talking about cranial nerve 8. And if you don't know your cranial nerves Roman numerals, I would definitely know those for your exam. A lot of times the exams only use the Roman numerals when they are talking about the cranial nerves. So this can be caused to just simple damage to cranial nerve 8, which is peripheral, or there can be central vertigo, which is more serious. And we're thinking things like a stroke or a brain trauma. Most vertigo patients do have bouts of feeling like they're floating or the room is spinning. Sometimes when they're driving, this happens, which can be a little bit dangerous, and it's very disruptive to everyday life. And the maneuver we can use to diagnose vertigo is called the Dix-Hallpike maneuver. To perform this, we have the patient lie supine, and then we turn their head 45 degrees and hang it slightly off the exam table. So it might be a little uncomfortable for them while you're doing this in office. If this recreates the patient's symptoms, they say, whoa, yeah, I'm feeling it. We say it's a positive result, and that would indicate some vertigo might be going on. One of the most common causes of vertigo is Meniere's disease. And then we might see BPPV, or benign paroxysmal positional vertigo, which, believe it or not, can be treated with antiemetics. So for whatever reason, they work really well. The thought is they dry up any sort of fluid that's putting pressure on cranial nerve 8. So we typically see things like meclizine used. There might be more serious causes like acoustic neuroma as well. So if this is going on for a long time or not resolving with medication, we're going to send them out to ENT or sometimes even neurology. And then obviously a very serious cause of vertigo would be something like a stroke, and we're going to assess them with the BFAST assessment. and make sure they're not having a stroke, because we definitely would not want to miss that in office. So now let's do some practice questions. And these are right from our question bank. So if you are feeling like, hey, I need to practice eyes and ears, which is totally valid. Sometimes in school it is glazed over. You can head on over to our FNP Archer review, and the links will be at the end of this presentation, and sign up for our question bank. It is really robust. It's about over 1,400 questions. So it really covers everything you need to know for your exams. So let's talk about this question. Retinal detachment requires an urgent referral. Permanent and severe vision loss can occur if patients are left untreated. Healthcare providers must recognize and act. Knowledge of risk factors is crucial. Which factors place patients at a higher risk for retinal detachment? Select all that apply. Little reminder is select all that apply will only show up on your ANCC exams, but it's still good to practice for AANP. I'll give everyone a little moment to think about this. So if you C and D, you are correct. So a family history of retinal detachment, cataract surgery, and myopia are all risk factors, interestingly enough. This was just a pure recall question. Increased age is a risk factor for retinal detachment, not younger, as we know. So choice A was incorrect there. So if you didn't know this, don't panic. Something I always like to harp on is if you don't know everything on your exam, that is totally fine. These exams are really just making sure you are a safe novice nurse practitioner. So don't worry about it if you don't know the ins and outs. We don't need you to get 100 on these exams. We just need you to get about a 70% on each is passing. And the nice thing about our question bank is it always has additional information, links, pictures, things you might need to really pull it all together. So that is a really, really nice feature of the Archer Review question bank. It not only gives you the choices that are correct, but it also gives you some extra info if you need to look it up or clarify for yourself. So let's do another one before we say goodbye today. A practitioner wants to assess a patient's hearing. After reports, the patient feels they are constantly asking people to repeat themselves, something else we commonly see in primary care. They strike a tuning fork and place it on that mastoid bone, so that should be giving it away for you here, and ask the patient to tell the practitioner when they no longer hear the sound from the tuning fork. Then they place the tuning fork next to the ear, so they pull it away and ask the patient if they can hear any sound. What type of hearing loss are we looking for here? We have conductive, sensory neuro, mixed, or functional. So we're thinking about air conduction and bone conduction, if that helps you. Putting that tuning fork on that mastoid process, that mastoid bone. This is not fooling anyone, which is amazing because, like I said, the exams love these questions. So this is definitely conductive hearing loss. And again, this was a pretty straightforward one. So it is just telling you the practitioner performed the Rhine test, which is for conductive hearing loss. But it does give a nice little explanation here. So without the conductive hearing loss, the fork will be heard when held next to the ear. If the conductive hearing loss is present, the fork's ringing will be heard only when it's touching that bone. So BC would be larger or greater than AC with conductive hearing loss. You all did amazing on those practice questions. So now we have a few minutes left for some Q&A. If you have any questions about anything we talked about, and any general questions about Archer Review, or if you have any board questions, about AANP or ANCC, feel free to put them in the chat and I will get to as many as possible. And if you have in-depth questions about AANP or ANCC, we did a webinar last week all about the exams, and you can find that on our YouTube channel. Did a little deep dive into the differences of the exams. I see one about lipid levels. So eye exams, we always should be checking cholesterol. Something I do think about more than anything in the eye, well, a couple things. When we're thinking about high lipids, I think about xanthosmas. So those are the yellow deposits above the eye. They kind of look like little like mashed sand deposits almost above the eye. And then arcus senilis, which is a gray ring around the eye. We actually cover this in a different section of the review, but we are definitely concerned about lipids if we see the xanthosmas, which are above the eye, little yellow deposits. And once you know that, you are going to start diagnosing people in the grocery store, everywhere. Arcus senilis, which is a gray ring around the eye. And if you are needing more materials to practice, we have a question bank on our website that is over 1,500 questions. You can filter them by topic, by exam. They're really robust. They have really great explanations. So I would take some time to go through those. I always like students to do more than 2 full-length exams as well. We have some good readiness assessments, which I think can be really helpful to see where you're at and where you might need to beef up a little bit before your exam or going into practice. And then later in the year, well, not too much later, I can't believe it's always 2024, we are planning a full course launch, which will be really exciting. We're working very hard to make sure it's not too much information, but it's not just glazing over information, everything you need for your exams. I'll put this up too, just so you can have the basics of everything we have here at Archer FNP. A question came in, how much time do you recommend studying per day before taking the exam? This really depends on you and your schedule. For me, I like to study in bits. So I personally studied a little bit in the morning. I was still working as a nurse when I took my boards. So I like to study in the morning before work for about an hour or so, did some practice questions throughout the day, and studied at night. The main thing is you're not overwhelming yourself. So don't wait until the last minute. Make a plan, put it out over, I would at least give yourself 2 weeks, if not 4 weeks to 5 weeks, to really let it all sink in. I know some people take a whole couple weeks off of work or take a whole week off and just study 8 hours a day. That doesn't work for me, but it might work for other people. But really just knowing your study style. And if you have any questions that are more specific, you can always message us on Instagram or Facebook, or send us over an email at fnp@archerreview.com if you want some more personalized study advice. I'd be happy to help. A question about the best way to study. Videos, practice questions. This again depends on what type of studier you are. Videos can be very helpful. Practice questions are imperative. That is a non-negotiable. Do the practice questions, please, because there are only so many ways a question can be asked. You know, if you've done 200 hypertension questions, I almost can guarantee that on your exam, you are going to see a hypertension question of something you've already reviewed. So videos can be helpful. Some students like to write things down. There's really good evidence that writing things down or typing it up has a good way of putting it into your brain. Some students don't need the videos and they just like to read. We will have a live review coming up as well, which I hope you all join if you are going to be taking your boards this summer. But that just depends on you. But practice questions, non-negotiable. Don't make me hunt you down. You absolutely need to do those practice questions. We have time for a couple more questions before we wrap it up. And again, if anything pops up or you want some more specific advice, please feel free to email over to fnp@archerreview.com. I'm always happy to help everyone out. I know board prep and end of school can be a stressful time. All right. Memory tricks about the hearing tests. I like to think the Wibber test, I don't know why. I think of like a little chicken, like the little W on top of the head. And like I said, if it goes to the bad ear, it's conductive hearing loss. So the C's there, B and C are very close together. And if it goes to the good ear, I like to think good senses, sensory neural hearing loss. And then for the Ring test or the Rinny test, it's a little more straightforward in that bone conduction should be shorter than air conduction. So that one makes a little bit more logical sense when you think about, okay, the patient should hear it longer through the air. AC, air conduction, should be longer than bone conduction. And you can think all the C's go with conductive hearing loss. All right, it looks like that's all our questions and just about all our time we have for today. Again, if anybody has any lingering questions or anything like that, they can always email us over at fnp@archerreview.com. And we will be hosting these every Monday. So join us back next Monday. We will be talking about the nose and throat. So the rest of HEENT. I hope everyone has a great week. Thank you for joining me today. You had some great questions. I can tell you're all going to rock your exams. So I will see you next week.